live.
Okay, afternoon everybody. Lovely to see you if you are there, and if you're in our virtual gallery, welcome. This is the COVID-19 Prevention and Management Board public session, which means you have your chance, or members of the public from Sheffield have their chance to ask questions about the coronavirus and this pandemic and what's happening in Sheffield to our Director of Public Health, Greg Fell. But in the meeting, Greg does a situation report as to where we are, and then members of the board can ask questions of Greg, but also then we go to public questions. We do ask people to send them in, but if you come to the meeting, we do take some from the meeting as well. I'm Councillor Jackie Drayton. I'm the Cabinet Member for Children, Young People and Families and have public health in my portfolio area too, and I'm a member of the COVID-19 Prevention and Management Board, and I'm the Deputy Chair and filling in for Councillor Bob Johnson, who is the Chair and unable to get here today. First of all, I'd like to introduce the members of the board that are here today. And the first one is Councillor Mohammed. Would you like to introduce yourself? Thank you.
Good afternoon. My name is Shafaq Mohammed. I'm a councillor for the Ecclesall ward in Sheffield and leader of the Liberal Democrat opposition in Sheffield Council.
Thank you. Lou, can you hear me? Would you like to introduce yourself, please? Thank you. We still can't hear you.
Sorry, that was a schoolboy error there. Good afternoon, my name's Louisa. I'm one of the executive directors at Sheffield Chamber.
Welcome, thank you very much. We've got Dan as well. Dan, do you want to say who you are, please?
Dan Spicer, I'm Strategy and Partnerships Manager for the Council, providing support to the board.
Thank you very much, Dan. And then now it's over to Greg Fell. Do you want to introduce yourself, and we'll start with the situation report, please?
Great, thanks, Chair. So I'm Greg Fell, I'm Director of Public Health in Sheffield, and I shall then do a situation report. I think Dan, you're going to control the slides, aren't you? And I get to do what I've always wanted to do and say, next slide, please. Let me just organise my technology. So situation report dated today. All of the data is up to date as of yesterday, or very recent data. So Dan, shift on to the next slide, and I'll cover off what I'll talk on. So four things. Epidemiology, as I say, up to date as of yesterday. Vaccination is again up to date as of yesterday. Short-term forward look covering most obviously the roadmap and a brief bit on what's in it, but people will have read it, but I'll give a brief overview of my take on some of the key bits, and then looking forward to the long term, because the roadmap is medium term at best, and I'll do a little bit on what the longer term may look like, accepting there's some crystal ball gazing inherent in that, and then a reminder of the basic strategy, which, to cut to the chase, is largely unchanged. So Dan, if you move on to the next slide. In short, the lockdown that we are currently in is hopefully coming to an end in a not too distant future. It is doing the job that was expected of it, and this is the Apple analytics data. So for those who have iPhones, the iPhone in your pocket monitors where you go. And how you get there. Quite how it does the wizardry, I don't know, but it's commonly used metric to get a sense of mobility, and currently mobility is somewhere somewhere in the territory of the end of the first lockdown, the end of the March 2020 lockdown. So mobility is in about that space. So and it's held, actually. There have been some jittery moments in the lockdown, but it's largely held. So Dan, next slide, and then we'll see where we are epidemiology wise.
Sorry, Greg, can you just remind us what mobility means, please? Sorry.
Our movement, our movement around the city, and how we move around the city. Sorry.
And how many people are out and things like that, and where they're moving and if they're not moving. Thank you. Thanks very much.
Okay. So Dan, the epidemiology. So epi-wise, in short, largely good news with some cautions. There's been a long-term decline in the 7-day incidence. So the number of people diagnosed with COVID-19 per 7 days per 100,000 people. A week or so ago, it was about 150. It was trending towards 100, certainly got down fairly recently to about 110. Now stalled. So the rate of decline has stalled and is flatlining on about 120 or so. There are a number of reasons for the stall. The two principal ones are that we had an arguably artificially low number. When we got to about 110 per 100,000, it was artificially low because we had some snow days a couple of weeks ago. And the reality is people don't go out for a test on snow days. So that was suppressing our numbers artificially. Secondly, very practically, the Meadowhall regional testing site was resurfaced. The road was resurfaced last week. So again, that will have artificially suppressed the numbers being tested, therefore the numbers of people getting positive tests. So currently we're on about 120 or so, and it is fairly flat at the moment. Hard to guess where that will eventually settle. I think we will see a continued slow decline up until early March, and then I think as we start to unpick the lockdown, it may start to go up again, which will be notable, of course. Importantly, the bottom right graph is the steady but fairly long-term decline in the rate in over 60s, clearly the group that are most likely to be harmed, which continues to go down. And I'll pick up on that later because we'll get onto vaccination, and also the overall population rate because continues to go down. But you can see the flattening off of the shape of the curve in both of those graphs. So Dan, next slide, please. There's a recent uptick in the working age population, and you can see that for yourself. In the largely older groups, age-specific instances continuing to decline, and largely children and young people continuing to decline. For both of them, relatively steadily. Working age has just started to go back up again. It's a group that are out and about at work. They're out and about. They go to work. Therefore, there's more chance of exposure, and there's more chance of becoming infected. So it was to be expected, and I think the impact of the new variant will put an upward pressure on the level of infection for some time to come. Almost all of the infections in Sheffield now are the Kent variant or the B117 variant, and that is more transmissible. So we'll put an upward pressure on infections. Much has been made in the media of the South Africa or the Brazil Manaus variant, neither of which are in Sheffield that we know of at the moment. That's probably a matter of time, a matter of when, not if. But currently, the variant that's in Sheffield is the Kent variant. Same across the country. More than 90% of all cases are the Kent variant now. Being blunt, it's good in a fight, and has become the dominant variant up and down the country. So, but just to underscore the point, the recent uptick is principally in the working age population. That accordingly will shape our strategy as going forward. So, Dan, next slide, please. Fairly evenly spread across Sheffield, but beginning to have some more geographic concentration in the east of the city. So a version of this graph 3 or 4 weeks ago would have shown most of Sheffield was somewhere between pink and red. The deeper the red, the more cases in that particular geography. But as you can see, if you roll forward that graph, and this is a graph from yesterday, grey means no cases, and increasingly you can just begin to see concentration of cases in the east of the city. That's where there are more people who have manual and or service sector jobs that just can't be done, or manual manufacturing and or service sector jobs that just can't be done from home in the same way my job can be done from home. I've been at home for longer than I care to remember now. So accordingly, there'll be more infections. Most of the infection is related to within and between household mixing, which is why essentially the ban on mixing between households up to now has been really important, because it has made a difference. But where infections are happening, it's mostly in and between households. And that has been the case from the start, probably will be the case until the very end. So Dan, if you move on to the next slide. Just to give you a sense of where Sheffield compares to the rest of South Yorkshire, Sheffield is the yellow line in that graph. Our rates are lower than the rest of South Yorkshire, and you can see that's certainly been the case for the past 2 or 3 weeks now. We've had a faster decline over the past 2, 3, 4 weeks. But again, you can see the flatlining of the yellow in the bottom right-hand corner of the graph. The reason for the lower rates is partly because we've got lower testing in Sheffield compared to other parts of South Yorkshire, for reasons I don't know, and partly because when the economists have crunched the numbers, there's a greater proportion of the Sheffield population, or the greater proportion of the Sheffield population who are working, who are able to work from home, than the economies of Rotherham, Doncaster and Barnsley. So that those two things account for the difference. It remains to be seen whether the rest of South Yorkshire will catch Sheffield up, or where that graph will go in the future. There's some speculation there. So that's how we look compared to the rest of South Yorkshire. So Dan, move on. Headlines, epi wise. The R is below 1, but only just below 1. We don't have a city level estimate, but looking at Yorkshire and Humber as a whole, R is somewhere around 0.7 to 0.8. So every 100 cases will lead to 80 new cases, which means that the epidemic will shrink, but shrink relatively slowly. My preference clearly would be R is well below 1. So when last spring, early summer, when lockdown was released first time, R was about 0.6. So we're not there. 6.5% of all people who develop symptoms and get a test positive. 2 or 3 weeks ago, that was 12%. 3 or 4 weeks before that, it was 15-16%. So there's a lot less disease around at the moment. All of the population prevalence of COVID-19 is about 1%, there or thereabouts. So 99% of people don't have this illness, but at any one time, 1% of people do. So and that's going in the right direction, and that will continue to go in the right direction, we hope, with some caveats. Cases are increasingly unevenly spread across Sheffield, and the incidence is coming down in some, but not all age groups, and is still quite high. Hospital activity, much is made of hospital activity, it is coming down. A couple of weeks ago, 20% of beds in Sheffield Hospital had a patient with COVID in them. Now it's about 15%. It's still really high. Imagine trying to run a hospital with 15% less beds than you were used to. That is a very, very difficult operational problem for the hospital. To their credit, they've managed it exceptionally well, and the same can be said for the rest of the health and social care system. All of the focus is clearly on hospitals, but both primary care and social care are exceptionally busy also. So, and that's going in the right direction. It's coming down, but it's coming down from quite a high level, and I think it will slowly decline. Looking more broadly, epidemiology across the rest of the country, all is going in the right direction. All spaces are going fairly slowly, but all heading in the right way. Slightly slower decline in the East Midlands, the Northwest, the Northeast and Yorkshire, largely on account of different structure of the economy, more manufacturing jobs, more service sector jobs that need to be done face to face than in other parts of the country, and actually less people, more poverty, and that's an implication in terms of the affordability of isolation. So the decline in the north is slower than the decline in the south, and that is a concern. That will become a big issue, I suspect, over the next 2 or 3 weeks, certainly with a longer time timeframe it will. As to use a phrase, as the tide goes out and the rates get really, really low, the places where there are obvious ongoing concerns will become much clearer. I don't think Sheffield will be in that space, but it's possible. And again, we think that the rate of decline will tail off. The Zoe app, which many people use, which is not a really strong piece of evidence feed, but it is an important one, is very clearly telling us now that the rate of decline is falling off. What is important is that if you look at the rate of infection in the over 80s, which were the first group to get vaccinated, that is now visible to the naked eye. It wasn't a few weeks ago. Someone's calling me, sorry. What wasn't a few weeks ago, but the rate of decline in the very elderly of cases is now visible to the naked eye. So the impact of vaccination is very, very definitely being seen at the moment. So that's about where we are, epidemiology. And then Dan, if you move on, I think I'll talk vaccination next. I will. Vaccination is excellent story, excellent news. So well more than 170,000 people in Sheffield have been vaccinated across 15 primary care networks and the Arena, which is the mass vaccination site. Fairly relentlessly focused on the initial 9 cohorts that were recommended to government by the Joint Committee on Vaccination and Immunisation, which is what JCVI stands for. And we are relentlessly sticking to that for some reasons I'll come on to in just a sec. Currently, we're vaccinating those age, or we're pushing to get vaccinations done in those aged 65 to 70, cohort 5, and those with underlying conditions, cohort 6. The underlying conditions is basically adults aged 16 to 50 who have an underlying medical condition and or who would normally be recommended for a flu jab. So that includes people who have disability, and it also includes carers, informal carers. And yet prospectively identifying informal carers is proving very difficult, but we're on with that, and we're pushing quite hard on that at the moment. For those who are in JCVI criteria 1 to 4, so people, very elderly, those are residents in care homes that for some reason didn't get the first dose, then there is there's a website and or a phone number, and I'll pick that up later in questioning, that you can book an appointment. So, but the active appointments, we're pushing forward pretty quickly now for as I say, those between 65 and 70, and then younger adults with an underlying medical condition and or younger adults who have a disability and or informal carers. The data on the impact of vaccination is becoming abundantly clear now. The clinical trials told us that the being vaccinated protected individuals from severe illness and or death. And that was crystal clear from the clinical trials. That's now beginning to be seen in practice in real life. As I say, if you look at case rates and certainly hospitalization rates for those that have been vaccinated, we're beginning to see it very, very, very clearly, very abundantly, i.e. vaccination is doing what it said it would do on the tin. Israel is the poster child for this, and Israel's about 2 or 3 weeks ahead of the UK, and it's absolutely clear in Israel, and it's beginning to be very clear in this country. The other great news is the impact on transmission. The thing that none of us were clear on a month or 2 ago was, if I am vaccinated, am I less likely to be able to transmit the virus? And that has implications in terms of the spread of the virus, obviously. No one knew the science up until relatively recently. Public Health England published their paper on this earlier this week, as did the Scottish Government published their paper on this, and being vaccinated significantly reduces the chance of transmission of the virus, which is obviously a good thing. Other things that's worth me picking up on vaccination, we are saying no to lots of groups that aren't within JCVI criteria 1 to 9. That's proving difficult, proving very emotive, and is proving troublesome for lots, including me. There's an awful lot of demand for the city, not just happening in Sheffield, it's happening across the country, to move away from the focus on the Joint Committee of Vaccination Immunisations Criteria 1 to 9. The bottom line is there are any number of groups, occupational and or otherwise, who can make a legitimate case for earlier vaccination than is going to be the sort of the normal schedule. In the context of limited supply, and there is limited supply, which is far from perfect. Actually, the supply chain isn't half as smooth as any of us want it to be. But in the context of limited supply, bumping up the prioritization order of Group A, Group B, or Group C bumps down somebody that's, or a group of people within the JCVI criteria 1 to 9, and that carries consequence in terms of increased or more residual risk of death and severe illness. And the point of the vaccination programme is to minimise death and severe illness. So for that reason, the city and every other place up and down the country is holding quite a difficult line on that one. There are circumstances where some places have gone off the JCVI criteria. That doesn't make it right. I mean, it doesn't make it right to go off the JCVI criteria in Sheffield, and that's proving very, very difficult. It adds a whole sense of unfairness into the mix, and I completely acknowledge that it adds a whole sense of unfairness into the mix. But it equally is not fair to somebody that's 65 that their vaccination is delayed on account of vaccinating another group of people. So there's no right or wrong way around that one. The only other point I would say on vaccination, or two other points on vaccination, is that whilst the evidence is increasingly stacking up that being vaccinated reduces the risk of transmission, we're still asking people to observe social distancing, wash hands, wear face coverings, etc. What we're desperately trying to avoid is a scenario where there's unmitigated spread of the virus in an unvaccinated population, and there's still significant part of the population. So 400,000 people, nearly 400,000 people in Sheffield who are unvaccinated. It's a really easy to spread, dangerous respiratory virus that kills people. At the level of infection we've got, it still causes substantial harm to individuals. Our hospitals still have lots of people who are much younger than you might imagine in intensive care with COVID-19. Transmission also increases the risk of long COVID. I don't personally know anyone that's had long COVID, but from what I'm hearing, it isn't something I would wish on anybody. 5 to 10% of all infections end with long COVID. So you're reducing transmission in unvaccinated populations is in itself good for that reason. And thirdly, each time the virus replicates, there's a chance it mutates. And what we all want to avoid is a vaccine-resistant mutation of the virus, because that sets us straight back to square one. So for those reasons, we're asking everybody to continue to observe the social restrictions that are in place. Last thing I'll say on vaccination before we move on, there are currently no plans to vaccinate children. It's the vaccines that we're using aren't even licensed in children yet. That may come down the line, and there are some trials starting. But they're a good way off, actually. But we are actively planning as a country and as a city to begin to vaccinate adults, as per the Prime Minister's announcement in the roadmap from earlier this week. So we were aiming to have an offer to all adults to have been vaccinated by early summer. I don't know the exact timetables, but we're actively planning. But JCVI criteria 1 to 9 remain the top priority vaccination-wise. So Dan, move on. The roadmap. I'm not going to dwell loads on the specific steps within the roadmap. It's a long document, and we should all take some time to digest it. But basically, there are sort of 4 steps between the 8th of March March, step 1, and the mid to late June, step 4. And there's a very, very deliberate 5-week period between each step. And the purpose is to allow us all to check and test what has been the impact of implementing step 1 and step 2 on the levels of circulating virus, importantly the harm that comes from that circulating virus. So there were 4 tests that government set out. One was the continued rollout of the vaccination programme. Secondly was hospitalisation, which is a marker of marker of transmission, but obviously that's ameliorated a little bit, a significant amount by vaccination. And there was a third test around the government's assessment around where we are with regard to variants of concern, the South Africa and or the Manaus variant. So at each step, governments will test using a set of criteria what has been the impact of unpicking that element of the lockdown before it moves on to the next step. And whilst government are saying that they will be irreversible, I wouldn't bet against a shift on policy if there's a significant untoward impact from one or more of those 2 steps. So I welcome the roadmap. I think it's actually really, really helpful. But it is fluid. It's in a fluid and uncertain environment. So I think the onus is on us all to continue to act carefully and sensibly to limit transmission as we go forward. So Dan, next slide. Just my personal thoughts on the roadmap itself. Welcome slow and cautious approach. School opening, quite rightly, is step 1, 8th of March, and the Prime Minister's committed to that. I think the government are committed to reopening schools for obvious, very good and understandable reasons. Kids not being in school also causes harm. There will be an impact on cases of school opening. There's no 2 ways about that. If we bring groups of humans together, there will be passage of virus, because there is still an appreciable level of virus in the community. So, but that is something for us to be watchful for and to manage as carefully as we can. And credit to the schools of City, have done an amazing job thus far, and I think will continue to do so. Lots in the roadmap on vaccination and the development of asymptomatic testing. Both are important tools to reduce risk, particularly the former. Vaccination is one of the routes out of this. It's not the only route out of it, but it is definitely one of the routes out of it. Arguably, in my view, not enough in the roadmap on the basics. So the basic infection prevention and control measures that are there. There was an important debate to be had about zero COVID, and Prime Minister was really clear that zero COVID is probably not achievable. I'm really clear zero COVID is not achievable. There's too much circulating virus. Zero COVID is achievable if you live in Antarctica, but probably not if you live in Sheffield. So we're aiming for as low a level of viral transmission as possible. There was further funding announced for local government for outbreak control. We need to make sure that we use that appropriately. The roadmap was actually quiet on inequalities, disappointingly so. This has been an illness of inequality, and it was relatively quiet. Now we can choose and will choose, I'm sure, locally to focus some effort and energy in that space, but the roadmap, the national roadmap, was quiet on that. It was silent on long COVID as well, and as I say, 5 to 10% of people who have the infection will develop long COVID, sadly. So I'd like to see more on that, and again, that's something that we can address. Relatively silent on the endemic nature of the illness, particularly in the north of England, where the structure of the economy is different to the south of England, and that I think will become a feature over the next few weeks. And as I say, I think maintaining the support of the community will be critical in spring and summer, and a long-term strategy I think will be needed, living with and adapting to. And I think the roadmap itself was relatively silent on the longer term economic and social recovery. That is one thing that certainly worries me. I think it probably worries us all. So much to welcome in the roadmap, and perhaps some more to do. So last point for me on the basic strategy. I think we have committed to undertaking a review of the outbreak control plan. I'm almost certain that governments are going to ask outbreak control boards to formally review the outbreak control plan. We've started that, but not quite finished that. But in short, the basics will remain the basics. The basic tools that we've got: testing, contact tracing, isolation, supporting a whole range of settings around prevention will remain the basics until the end. I think we will see, and I support wholly, more and more localization of some of the tools that are available to us, and that will be a good thing. So I'm going to stop there, if that's all right, and then I think people will probably want to ask me some awkward questions.
That's it. That's lovely, Dan. Thank you. Thanks very much, and thank you very much for that very comprehensive report, Greg. One of the questions, the written questions, I think you've answered some of the points that were in there, but we'll ask that person to come back later. But first of all, I just ask if anybody, any members of the board would like to make a question or comment. I believe Councillor Shafaq Mohammed wanted to ask a question or make a comment.
Well, actually, my question was something that Mr. Phil Edwardson, who's a governor at one of the special schools in Sheffield, has sent to me directly. I mean, I know he's watching, so he may text me again, Greg, if you don't like your answer. But obviously, Mr. Edwardson is a member of the governing body. What he's pressing for us is pressing to get staff who've worked throughout the pandemic to be vaccinated. Mr. Edwardson is pointing out that staff in Leicestershire, Derbyshire, and Notts have been vaccinated. And I think from his information he sent me, there's about 1,000 SEND staff and public staff across Sheffield. And he rightly points out, Greg, that at the moment you are refusing to budge from the JCV guidance. And I think the point that Mr. Edwardson's trying to make is that special school teachers in their activities are not, you can't distinguish between them and carers or being vaccinated. And he argues that they fit into the category 2, frontline health, social care workers, close care for children with physical and mental disabilities. So what answer can we give to Mr. Edwardson, and no doubt the 1,000+ teachers that he's trying to speak on behalf of?
So the only occupational group that we're providing vaccination for at the moment are frontline health and social care. And there's a standard operating protocol that's been published by the Department of Health, either the Department of Health and Social Care or NHS England, I can't remember which offhand, that sets out how frontline health and social care staff have been identified. Children's social care have been excluded from that standard operating protocol. The rationale is, by and large, children are at exceptionally low risk of significant or severe harm from COVID-19, unlike older adults who are at really quite high risk of severe harm from COVID-19, with the exception of those staff that work directly and in close contact with children who are clinically extremely vulnerable. There's a legit case there, and they're within the standard operating protocol. But beyond that, there are relatively few, if any, social care staff that work with children that are included within a standard operating protocol. I want to vaccinate. Well, it's not my call; it's a national call. I would want to see the vaccination of those staff that work in special schools ASAP. But the reality is that means that someone somewhere has to look a group of 65-year-olds in the eye and say, your vaccination has been delayed on account of this. And it does boil down to how we manage the risk. There is more risk in delaying the vaccination of the 60 to 65-year-olds or the 65 to 70-year-olds. And therein lies the problem. So the rate limiting step is the supply of vaccine, and it is limited. I'm well aware that there are groups of staff that work in special schools in other parts of the country that have been vaccinated. Quite often that was done before the standard operating protocol was published, and it doesn't necessarily make it right. So the point, the key nub of this is, if in the scenario we have, which is limited supply of vaccine, we have to ensure that we vaccinate those who are at highest risk of severe harm first. The flip side of vaccinating a group of people who are directly at lower risk of harm, or their cares, their charges are at lower risk of harm, is we leave a group of people who are at higher risk of harm uncovered for longer, and that also carries consequences. I'm very, very aware it's highly emotive. I'm very, very aware of the inherent unfairness that some areas have gone further or interpreted differently, and that puts us all in a difficult position. But as a city, we're pushing a fairly strict interpretation of the JCVI's criteria, and I'm more than happy to be personally and professionally accountable for that.
Thank you, Shafak, and thank you, Greg. If I could just add something, when I was reading I was reading a little bit about what the JCVI had said, and it was interesting because they want to stick to this age-based approach for the reasons that Greg has said, but also it is about tackling those at higher risk. At the moment, we know are the older ones and the ones as we come down, but also because they feel it's an easier and simpler method to enable most of us, all of us, to get vaccinated sooner. So that's the other argument they said. It means that as we go through, we can get on and to the next and to the next. And the evidence is very clear that those most likely to have severe outcomes and to die from COVID are the older people or those with other things. And also the other point that they make is there's a potential, it would be more complex to decide we're going to go through different routes of different people in different workplaces, so different occupations, because who decides which occupation they are, which occupation is more at risk? Is it somebody who's working in a supermarket, for instance, every day, meeting everybody every day who's going in there, in and out, to somebody's teaching in a school? Is it somebody who's, emptying our rubbish bins? Or is it somebody who's a police officer? Or is it somebody who's driving our buses and getting people who need to work? And their point is that once you get into that, you end up, that takes longer time, and there is the capacity for missing people out, because they will be missed out. So that's the reasons that I've read, and I felt comfortable when I read those. The reasons they're doing it is it's quicker, we'll get more people done, therefore we'll get all people done. And in the end, even though I recognise, and I am really pleased that the government announced on Wednesday that all individuals on the LD, the Learning Disability Register, will be vaccinated. I thought that was really important, but they would or should have been in tier 6 anyway, and we are doing that in Sheffield at the moment. And finally, I just want to finish by saying, and I'll bring Greg in, please, 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 just to remind people, if you get the call, please do go out and get vaccinated. It is really, really important for all the points that Greg has raised. Greg, do you want to come back?
Just to add, I think once we get to the end of cohorts 1 to 9, which first dose won't be that long. I genuinely think we're talking weeks to a month and a bit at the outside. Yeah. I do think we will then get into an interesting space about what next, and we'll probably shift. Now the policy will probably shift nationally towards something that is based on transmission and or things beyond direct clinical risk, which I think is entirely appropriate, but it does, as Councillor Drayton's told us, puts us in the awful position of trying to determine which occupational groups are more valuable than those, and that they are entirely value judgments, and there's no way of making those. The one other point that I must say is that most people on the groups 1 to 9 will soon have had their first dose. You must get your second dose.
Yes.
Yeah, the city is actively, we're beginning to do second doses, but we will soon be running a system where we're trying to get through the rest of cohorts 1 to 9 dose 1 and cohorts 1 to 9 starting with 1 and then working downwards dose 2. So this will be an industry in this and every other city for certainly the next 3 or 4 months. It's an industry that's working really, really, really quickly, and credit to the NHS for that, actually.
Yes, thank you. I've got, thank you very much for that, Greg. No other questions. Oh, sorry, did you want to come back, Shafak? Yeah.
It's a different point, and I think it reinforces, I'm trying to reinforce what Greg said. I got that through the post this morning as an invitation to a vaccine, and I just want to say to everyone, I've already booked this weekend, and I urge anyone else watching, listening, to do the same. As Greg said, it is there to help us save our own health and well-being, but also to protect the NHS. So I'll be taking the vaccination because I'm in a vulnerable group in that category that Greg talked about, that's just been asked to take it because I've got a long-standing health condition. And my message to anyone watching is, please take the vaccination as soon as you get the letter, and do exactly what I did, which is log on and book your appointment. And there's some fantastic facilities across Sheffield that are willing and waiting for us. So I just want to make that point. Sorry, Greg.
No, that's really good, and a good reminder too, Shafak. I've had mine, and like the Queen said today, we're not just doing it for ourselves, we're doing it for the other people that hopefully will keep them safe as well. So, and again, just remind people, don't forget your second one coming up as well as going to your first. We're now got no other questions from the members of the board, but we have got a question from a member of the public who is here today, I believe, Mr. Adam Butcher. Could you bring him into the room, please? Hi, Adam. Good to see you. You're on. You haven't got your mic switched on, Adam. So if you'd like to switch your mic on, we'd love to hear your question, please.
Good afternoon.
Afternoon. Would you like to tell us ask your question, please, Adam?
Yeah. How can Greg's only he has actually answered some of the question already.
He has, yes, that's right. Yeah.
How can we make sure people in disability can actually understand the roadmap from and make sure that they understand the roadmap and the new regulations that come in with it? I've also been sent, Chair, an extra question by a family carer, and if that's possible,
yeah.
Why?
If you just
also answer that one as well.
Hang on a minute, Adam. What we'll do is we'll take your first question first and answer that, and then I'll come back to you and you can ask your second question. Is that okay, or the question that's been sent to you? Lovely. So Adam's question was about how can people with learning disabilities and be sure, how can we be sure that other people with learning disabilities will understand the rules, if you like, with the lockdown when they come out. It's really quite interesting, and I think it's really important that people with learning disabilities do understand them, but it's also important for all of us, because I listened to, I listened to it, I read it, and I'm still not sure if I quite understand everything, but I know that our comms team, I'll let Greg come in, but I know our comms team are going to produce some specific communication information, that the sort of thing they hope will be easy to understand. It's going to be a table, a CANI, and it's a table of the new rules with a red, amber and green traffic light system saying the different things. So if you ask a question around whatever, it'll go red, not yet until X amount of time. And it's like, can I have a haircut? You know, well, no, you can't on the 8th, but you can on the 16th or whatever. You can, you know, it's red on that, whatever. So hopefully that will help. But also, I know the government have said that they're going to work with disability groups to get that information out in a format that's easy to read, and hoping, and I know the organisations across our city will be doing everything they can to get that information out. Greg, did you want to come in with anything?
No, nothing much more. I think you've covered it, Jackie. I'll just the can I table. I'll screen share it so that people can see it.
Oh, good, yeah.
I won't go through it all because it's 17 pages long. So Magda in my team produces it every time there's a change in rules. Magda in my team produces the can I table, and it looks something akin to that. It's very widely used by all sorts of people for all sorts of reasons. And I never keep up with all of the rules. I always use the can I table. So it is the standard one. And yes, to answer Adam's to answer your question, Jackie, the when can I get my haircut is the top of my list of things. But more seriously, with that gets fairly widely circulated. I know our comms team have plan to do or have done and plan to do more, a range of stuff, as does Disability Sheffield, who've done an amazing job actually in producing really simple, straightforward, practical interpretations of what can and can't be done at various points. So and we will continue that. We can always do better, but we'll certainly continue down the path that we've got. And if anyone has suggestions better, I'm always keen to hear them.
Yes, thank you. And I'm sure, and thanks for the question, Adam. We'll keep an eye on it. I'm sure that there are a lot of families out there who are desperate to see their families, and you know, we've got to wait a little bit longer, but maybe that's best, because when we do finally meet, we won't go back, because what we don't want is going, I was thinking about the steps, we don't want to get to forget how infectious this illness is, this virus is. Thanks. Adam, you've got another question. Would you like to ask that now, please, from another person? I know, but thank you.
You've probably mostly answered it already, Greg, in your presentation, which I think was, I've actually had a family carer who come to me. His partner's already had a vaccine, but because he's classed as an unpaid carer and he's a family carer, he's still not eligible to get the vaccine. So how can we make sure that the unpaid carers and family carers are actually having the vaccine as well?
Unpaid carers should be in cohort 6. I'm fairly certain they're in cohort 6. Basically, anyone who's identified as a carer should be in cohort 6. The best thing to do would be to make sure that that person registers with their GP, or registers that they are a carer with their GP, and that way they'll get invited. There are probably an awful lot of carers that the system doesn't know about, because they've never come forward and identified themselves as a carer. So the best way to do it is to make sure that person's GP knows that they are an informal carer. That way they automatically get put on cohort 6 and they get invited.
I think that's it's a really important point that you've raised there, Adam, and that Greg's replied. Often, maybe if the invitations are going out by the GP, if they don't know that person is a carer for his partner or child, then they won't know to put them on the list. So that's a good thing. And the other thing I would just going to say, that certainly I know across the city, some areas are further on in list 6 than they are in other areas. So I know one of my children who's got anyway, she's got hers, but her brother hasn't, you know, but they're not over, you know, they're in that category. So another question, did you want to say anything back, Adam? Sorry.
No, but thank you very much, Greg.
Thank you, Adam, and thanks for coming, really appreciate it. Did you want to come? Sorry, Shafat wanted to come back.
Yeah, I've got a separate question, unless Greg wants to add anything else to what
No.
Adam was saying.
No.
Okay, so my question, I got a question. I got sent a link last night, Greg, from a friend and colleague of mine about a Mail Online article, which talks about 60% of people in the Isle of Wight have had the first jab, but then says, but rates in Sheffield are 20 times lower in one district. Now, I've done a bit of digging here, Greg, and it's referring to what we term as Cathedral, polling district, and Kelham, which is basically the city centre. And they're saying that in Sheffield, the jabs is just, 3.19% of the 21,000 residents, which obviously clearly will cause a bit of alarm. And I think what we might need to do is just put a bit of context behind exactly who lives in that part of the world and what the demographic is, just to put some people's fears to bed. I think, Greg, I'll let you kick off. I might add to.
Could I just add, can I just add one thing just before I let you come in? Sorry, just to say, thanks for that question. I think it's really important. And I was listening to Radio 4 the other day, and they were talking about certain areas, having the information to know exactly how many people have had the vaccines in certain super output areas, in certain smaller areas of our city. And I think I did ask if we could have it at our next prevention and management board, if Chris or somebody from the data team could actually look at that across our city, Sheffield, and give us the information so we can highlight some of the areas that perhaps aren't, and analyse why, and then work out ways in which we can make sure they are being given, the vaccines are being given, or people are going to have them. Okay, Greg, bring you in now, Greg.
Three thoughts. The Daily Mail headline is probably correct. The story is probably correct. Won't be for me to challenge the Daily Mail's accuracy. It's probably correct. The issue is the nature of the population. So both Kelham and Cathedral, very, very young population. Unsurprisingly, very few of them will be eligible for the vaccination. There will be one or two, but very few. And it's a fairly transient population, particularly Kelham's a fairly transient population as well. And the denominator population keeps changing. So the last fixed point we've got on the denominator is the census, which is 10 years old. And in the context of a reasonably transient population, the denominator keeps changing. Therefore, the accuracy of some of that lower and middle super output area data, it's a bit suspect, to be honest. It's not to say that the Daily Mail are misreporting it, but the context that goes around it is actually probably the thing that makes the difference. One of my concerns is that the way in which the supply is working is meaning that practices or primary care networks in poorer parts of Sheffield are actually getting less supply. And that is the rate limiting step in terms of the numbers of needles that are actually stuck in arms. And there are some problems with the formula according to which the supply is working, which NHS England have clocked their sighted on, and hopefully they'll resolve them fairly quickly. But it means that in Foundry Primary Care Network, which I think serves Firth Park Darnall type of way, they're getting less supply. And they're actually having to work a lot harder. So Jenny Joyce, the clinical director of that primary care network, she did a pop-up clinic in Firth Park Mosque about 2 or 3 weeks ago, where she spent the whole day talking to Muslim elders, didn't stick a single needle in a single arm, but she spent a whole day talking to people. That built trust over a long period. So the work that's having to go in to stick needles in arms is the other thing that's actually making the rate of coverage a little bit less equal than it needs to be. So we're aware of that, clocked that, and working on that as hard as we possibly can. And we've asked NHS England to resolve some of the fundamentals. But so all of those nuances are all in the mix. When you read those Daily Mail headlines that X has 60% coverage and Y has 2% coverage, yeah, it's probably true, and there's a lot of reasons for that. Some of those are good reasons, some of those are less good reasons.
Thanks very much for that. Did you want to come back?
Yeah, I mean, I just wanted to say, just via this kind of platform, that actually Sheffield's not unique in this. You know, the university area of Manchester, Nottingham and Leeds, they're all similar. But I just thought if people saw the headline, they're going to be quite alarmed to say that why is Sheffield 20 times less? It's because we've got a young population, as Greg says, pretty transient, and clearly, thankfully, unlike me, don't have long-standing medical conditions. So therefore, they're not going to get the jab. But I think it's right and proper that we do I thought we'd flag it today, Greg, just to make sure that if people did see it, they'll at least we can give them some context about Sheffield's situation. And I think that the example of the mosque is fantastic. It's in Jackie's ward. I mean, Jackie, I don't know what feedback you've had.
No, definitely. I was just going to say the Foundry covers Burngreave and Firth Park, the Foundry network, because that's where I went to have mine. And certainly I know that they're doing a tremendous job, but I also know that's where people who are in that group, in the 6th group, aren't getting their vaccinations too. So that's why I asked as well to make sure we do have a clear view of how many in each area for the next board meeting, Shafak, that we look down into that and just check. I understand completely about Kelham and about city centre, a different age, but in other areas where we know potentially as well in the east of the city where there's more community transmission and there's also more cases, because those people are more likely to be working and going out to work on buses, on public transport, and working in our shops and in our health services and out there on our buses. That we need to make sure those people are getting vaccinated when their time has come, sort of thing. So that's something. So thanks for bringing that up. But we are doing a tremendous job. We know we are. You know, what was it you said? 130,000 people? No. Sorry,
170. 170. Well more than 170.
That's it. Sorry, 170,000. Sorry, 170,000. But we still got a lot more to go. So, and if we know that some areas aren't getting enough vaccine supply to do the people who need to be done at this level, we need to make sure, and I'm sure Shafat would back me. We'd all back each other in making sure that we get that to the people down in London, that we need this vaccine to come to Sheffield. Thanks very much for that. I don't think there's anybody else who asked a question from the gallery, and I don't think we have any more questions. So if that's okay with everybody, I think we've done everything. Thank you very much for attending the meeting, and thanks Greg for giving us an update. Really appreciate it, and thanks everybody for all your questions. And don't forget, we have these meetings monthly, so if you want to put a question in, do put a question in. If you want to come along and ask a question of Greg, we're always here to answer your questions. Thanks very much, everybody.
Thank you.
Take care and stay safe. Bye. And have your vaccine if you get a letter. See you. Bye.
Yeah.